So although we're going to be focusing on the local mental health teams, I thought I'd just start by kind of giving you an overview of kind of where the local mental health teams sit in Nottinghamshire Healthcare Trust, because it is a big trust. So obviously the trust is divided into three big care groups. So we've got the forensics care group, which is where you'll have all your community forensic services, your inpatient services that are low, medium and high secure, etc. within there. You've got your mental health care group, which is where all of your mental health services sit. And then you've got your community health and specialist services care group as well. So community health will be more physical health services like podiatry, healthy families, things like that, down to specialist services such as the nest services, etc. So within the mental health care group, we've got the four care units. So we've got mental health inpatient and crisis care units, which is where all of your adult mental health inpatient teams will be, and also your crisis teams. You've got your mental health community care unit, which is where all of your adult mental health community services will sit. You've got children and young people and families care unit, and then you've got your older people's care unit, which will consist of all of the services for people in older people's services. So that will be kind of age 65 onwards, and that includes their inpatient units as well. So for the mental health care unit, which is where the local mental health sit, this is just an overview of some of the main services that we have sitting in the community care unit. So we've got the local mental health services, deaf services, recovery college, early intervention service, individual placement support, so for people that are wanting to get back into employment. We've got our coexisting substance use mental health pathway and homeless mental health team, and our sexual violence mental health practitioner. And then we've also got young persons transitions. Now, when I say young persons transitions, they're not actually a big team. They're just a couple of people that are supporting transitions from CAMS into adult mental health. We've got our community rehab service, which is a fairly new service, and then our personality disorder hub. So then obviously bringing that down to the local mental health teams, we've got 11 across the whole of Nottingham and Nottinghamshire. So we've got 4 teams that sit in the city. We've got 4 teams that sit in Mid Notts and Bassett Law. And then in South Nottingham, we've got 3 LMHTs. So what does a local mental health do? So the local mental health team, they're locality based for adults who are struggling with moderate to severe and enduring mental health problems. And we predominantly see people between the age of 18 and 65. However, we do have people in our services that are over 65 that have probably been in our services longer term, pre kind of age 65, and they'll tend to stay with us unless there's a need that they need to go into older person services. But each LMHT, they provide a function of daily triage, screening, they do assessment, formulation. So just for those that may not know what formulation is, it's where the clinician and the patient work together to understand the patient's psychological difficulties, so what was the origins and how they are managed. So kind of in simple terms, why has the problem occurred and what's keeping it going, and that can be really good to kind of think about what they want to do next in terms of planning care, etc. They also do diagnosis where that's required, treatment, follow-up, and then joint working with key stakeholders and other providers where somebody's needs are quite complex and probably needs a multi-agency involvement. Obviously, the aim is to support people to reach their optimum level of recovery whilst maintaining and building connections with their family and community at the same time. The aim is that we try and get people to a level where they can manage their own mental health and hopefully go back into the community and not be reliant on the secondary services longer term. But that how long somebody is in secondary services can vary depending on their complexity and need. The LMHTs, they do consist of a large multidisciplinary skilled workforce that have a representation from a range of different disciplines. So just to kind of give you a bit of an idea of what that multidisciplinary workforce looks like, we've got lots of different roles within the LMHTs, and just to kind of point out before I go through them, can be sometimes some local variation in the membership within the LMHTs, whether it's down to vacancies or just kind of how they were configured within their areas. But there is work underway at the moment to look at where there might be some unmet needs for the LMHTs to make sure that it's equitable across as well. But just to kind of go through some of the roles, obviously all local mental health teams need a service team leader and a clinical team leader, and they provide the management and oversight of the whole team. And then within the team, we've got our community psychiatric nurses, we've got occupational therapists and occupational therapy assistants, we have social workers, consultant psychiatrists, and then under them we'll have a variety of different supporting medical team. We've got clinical and assistant psychologists. We have mental health and wellbeing practitioners in some of our LMHTs, and we also have advanced clinical practitioners who all are trained as non-medical prescribers as well. We also have some of our nurses that might do their non-medical prescribing as well and might have that as part of their skills. We have the individual placement support workers, associate nurses, health improvement workers who support people with monitoring their physical health and doing their physical health checks. We've got peer support workers, community support workers, pharmacists and pharmacy technicians. Obviously, every LMHT needs an administrative support to help it to run. And then we also have senior PCM mental health practitioners that are aligned to the LMHT, but they actually work in the primary care, so within the GP surgery. So the people that they see are not open to secondary care. But if somebody requires stepping up into the local mental health team, they can do that without the need for a referral because they're already part of the team. So how's a referral into the LMHT happen? So we have two types of referrals. We have external referrals. So these will be people that are not currently open to our services, and they will mainly come from services like the GP surgeries, primary PCNs, talking therapy services, or social care. And then we also get internal referrals as well. So these are people that are open to another mental health service within Nottinghamshire Healthcare Trust. So an example of that might be that somebody has come into secondary care into an inpatient service, or they've been open to the crisis team first, and those teams felt that they need follow up with the LMHT. So all of the LMHTs have a referral inbox email where the referrals will be sent into, and that can be via the adult mental health referral form, or it might be a typed letter with the relevant information included. Then within the LMHTs, that will then be screened or triaged by a qualified mental health practitioner. So the difference between screened and triaged are, so if a referral is screened, a decision would be made based on the written information. But in some teams, again, there is a bit of variation at the minute due to capacity, etc. But it might be that they also give the patient a call. So that'll be where they triage. So if they give the patient a call, it just means they can get more information about what's going on. It enables that person to be able to contribute and have a voice in terms of what they feel the needs are. And then following that, the LMHT will decide what the next steps will be. So it will be one of most of these things, really. It'll either be that it's felt that that person doesn't require to come into secondary services, and it might be that they're signposted back to their GP or the referrer if it wasn't the GP, with some advice and signposting options. An example of signposting options might be talking therapies if that person hasn't already tried talking therapies, or it might be another service in primary care. We also have a contract with Mind and Frameworks, so to deliver stabilisation on our behalf. So it might be that we look at that referral and think that that person will benefit from some stabilisation skills, but with that wraparound support of the LMHT. So we would refer on to that VCSE intervention. It might be that we think that actually they would be appropriate to be seen by the senior mental health practitioner in primary care if there's one attached to that LMHT, so they can step that referral back to that person and then they'll pick them up in primary care. Obviously, we could also accept them into the LMHT, and there could be two options. Either we don't know enough about the person, so we feel that they would need an assessment first, so they would be allocated to an assessment slot, or it might be the person is well known, has recently been discharged and has come back to services, so it might be that they don't need to go through an assessment again and that they could be allocated straight to intervention treatment. Or it may be that we feel that the referral would be more appropriate with one of our other internal services within the mental health care unit. So an example of that is somebody might be presenting with early warning signs of psychosis, and it might be we refer them on to the early intervention service. Oh, I think I've missed one there. And then obviously the outcome of that is communicated to the referrer and the patient. So whilst for those people that are accepted into the LMHT, whether that is for assessment or treatment, they will be added to a waiting list. Now, it might be that they're allocated to an assessment and they might be waiting for a few weeks or more for that, or they've been allocated to a treatment, but again, there isn't a worker available straight away, so they're added to a waiting list. I'm not able to give kind of rough times of waits for the LMHTs. It varies across all of the LMHT depending on what somebody might be waiting for. It can be different. But obviously they're added to the waiting list and then they're provided with information about what will happen while they're waiting. So those patients will be given information about mental health support that they can access while they're waiting, including the team's contact details and crisis information. And then waiting well information will be continued to be sent every 6 weeks to that person until they're offered an appointment. So those that do go through an assessment, the outcome of that again might be similar to some of those where we've screened, triaged the referral. It might be we do an assessment but don't feel that they need follow-up within the LMHT, so they might be signposted back to the GP with signposting options. Again, from that we could decide to refer them on to our VCSE intervention, or we could accept them into the LMHT for treatment, or again, the referral could be forwarded on to a more appropriate internal service within the mental health care unit. And again, the feedback is provided to the referrer and the patient about the outcome of that assessment. I'm going to hand you over to Natasha now for the next slides.
Okay, so here I'm going to talk about the actual different interventions that are offered in the LMHTs. So some of the current pathways in the LMHTs it's a personality disorder pathway, and they support the clinical teams with treating patients that have a personality disorder, as well as working with patients who have, on an individual basis, who have a more chaotic life and a greater severity of difficulty. Medical review and outpatient clinics, these are our doctors that do some formal diagnosis, prescribing, and just aid the treatment pathways with that second opinion. The psychology pathway, as Sarah mentioned, so they'll provide formulation and understanding of the patients and offer different interventions. They also play a key role in offering supervision and research elements to the LMHT staff to have a broader impact on the patients that the LMHTs are seeing. Occupational therapy, they'll provide assessment and treatment in relation to how a patient's mental health impacts their daily functioning and productivity. They work very holistically, looking at a patient's physical health, mental health, and social aspects, etc. Social work. The social workers provide support and specialist knowledge in safeguarding, housing, Mental Capacity Act, carers' rights, care packages. They're vital in liaising with our local authority colleagues. The care coordination lead professional roles are provided by all the different disciplines. So they could have a nurse, an OT, a social worker. It all depends on what the patient needs. And they keep in close contact with the patient to monitor them and coordinate their packages of care. The assertive and intensive pathway, this is about adapting an approach to treatment for patients who are difficult to engage. And the difficulties of engaging can be for various reasons, but normally due to psychosis and a lack of understanding of what they need to stay well. And there can be substance misuse elements also. And that's about meeting in places where they're more likely to engage, so they can meet in public places, go and see them at a time of the day that suits them better, and offering more frequent visits to those types of patients. And coexisting substance use, mental health and homeless pathways. Hayley will tell us more about that, but they're specialist services for people with those types of needs, and the same for the eating disorders pathway. CAMS to AMH transitions. This is about supporting patients who are reaching 18 and moving from child and adolescent mental health services into adult services, so the transition is smooth and avoids destabilising them. Next slide, please, Sarah. So I've got a couple of case examples for you here. Just to show the complexity and severity of some of the patients that the LMHTs see. So Lisa is a 50-year-old female and she's experiencing severe depression. She's had previous interventions within primary care that have not improved her mental health, and her quality of life is significantly affected. So the previous interventions have been trying different antidepressants, completing course of CBT with talking therapies. So the GP refers her to the LMHT and she's accepted. And the range of interventions that are offered to Lisa include seeing a psychiatrist to provide specialist prescribing of medication and monitoring the effectiveness and side effects. A psychologist sees Lisa fortnightly to help her make sense of her difficulties. And alongside that, occupational therapy to support her to improve her motivation, social contacts, meaningful activities. And she's also referred to the IPS worker to help her get back into employment. Next slide, Sarah, please. Another example here. So this is an example of the assertive and intensive pathway that I was just speaking about. So this is Mike, he's 31 years old. He has a history of psychosis and coexisting substance use, as well as a history of homelessness. And due to a pattern of not wanting to take his medication and not engaging with services, his mental health declines and he's admitted to an inpatient unit under a Section 3. And whilst he's in hospital, his medication is changed to a depot, which is an antipsychotic medication that's administered. And this is hoped to help him to remain on this medication when in the community. It prevents him from forgetting to take tablets, etc. So Mike's followed up by the LMHT after his discharge from hospital, and is monitored by a psychiatrist every 3 months. He's seen by his CPN, which is Community Psychiatric Nurse Weekly, where they work assertively and flexibly to promote the engagement and prevent relapse. The CPN will also administer the depot at these appointments. And then he's also seen by the specialist substance misuse practitioner. who's based in the LMHT to help him to better manage his alcohol use. Next slide.
I'm sorry, I didn't realise that was me. Hello, everybody. Thank you for that, Natasha. So yeah, my name is Hayley and I'm the SMD practitioner. So I'm just going to tell you a little bit about my role and some of the things that Notts Healthcare Trust are doing to better support patients who are experiencing SMD. So yes, my role is SMD practitioner and I'm part of the wider Changing Futures service. So for those of you that don't know what the Changing Futures service is, I'll make sure that we pop a link into the chat so you can have a look at that in a little bit more detail. But a part of the Changing Futures service is the role of SMD practitioner. So I work in Notts Healthcare Trust in the local mental health teams, but there are other embedded practitioner or SMD practitioner roles throughout those different parts of the system where somebody who's experiencing SMD is likely to come into contact with. So there are other SMD practitioners in primary care, social care, probation. A new person has just started within the emergency department, which is great. And so we all sort of have a similar role to each other to improve the experiences of people experiencing SMD within those respective services. So what do I do as part of my role is I'm based within the city local mental health teams, although that role does spread out a little bit more into the county and inpatient units as well. But I do have a city focus. So what I do is I'm around to provide advice, support, signposting for those local mental health teams if they have a patient who's experiencing SMD and they don't quite know what to do, or they might be a bit stuck. So I might suggest different ways of working with somebody, advice about how to reach out and engage them better, suggest other services that they might want to signpost into or refer into, and things like that, so that the person, while they're in the service, then maintains that engagement with the service and gets a good service, and then also sort of improve understanding and confidence of staff as well. And as part of that, I also link in with other pieces of work within Notts Healthcare Trust. So for example, I think Sarah was mentioning earlier around patients being written to while they're on waiting lists. So looking at how can we sort of make those letters a little bit simpler and a little bit more easy to read for everybody. And then also there's been some work around changing the way that we care plan. So again, coming along to that work stream, Natasha mentioned the assertive outreach pathway, or we're now calling it the assertive intensive pathway. Again, making sure that I'm involved in those different pieces of work to provide my expertise and present sort of an SMD lens really on any of those projects, to make sure that the needs of SMD patients are considered when we're developing new services or new pieces of work. One of the key things I also do is making sure that I'm linking in with other services and encouraging that joint work and linking with other services by the teams by the local mental health teams. So again, quite key with that embedded practitioner role and link with Changing Futures is I will often link in with my other embedded practitioners and find out if they're open to that service. So quite often I might ring up my my SMD colleague in probation and say, is your person open to probation, or contact Changing Futures, is your person open to Changing Futures? And if so, then making sure that those other the local mental health team is linking in with those other services so that they can provide that holistic support, that more wraparound support, and make sure that they're engaging that communication, because we all know, don't we, that if we're all communicating around the same person that we're working with, they provide they get a much better coordinated service. So Natasha mentioned earlier around, so that's sort of something that I do, and then some of the things that Notts Healthcare Trust are doing. Natasha mentioned around the substance use and mental ill health pathway. So what that means basically is that we have a substance use workers working within the local mental health teams, inpatient units and crisis teams, and then we also have a mental health practitioner who works in the substance use teams, namely NRN and CGL. So if you have somebody within local mental health team, for example, who is using substances but isn't already open to treatment in one of the substance use services, they can be referred into the substance use practitioner and get support that way. and that also means that they're getting support for their coexisting conditions, which is brilliant. And what it also means then is those practitioners are there within the local mental health team, sharing their knowledge, sharing their expertise with their colleagues in the team. Same goes the other way around. We have the mental health practitioners. I think there's just one in CGL, one in NRN, could be wrong, but I think that's about right. And again, if somebody's open to a substance use service, needs mental health support and isn't already open to a secondary mental health team, they can link them in with a mental health practitioner who can give them that mental health support, which is brilliant. And again, providing that knowledge and expertise for the teams that they're embedded in. We also have the within the county work, we link in with the MEME project, the Making Every Adult Matter project. That's something that my line manager works quite closely with in terms of the county, like I say, because I do have more of a city focus. And then we also have the homelessness mental health teams in the city and the county. They are quite small teams. I think there's just 2 people in the county and 3 in the city. But what they do is the nature of their service is it works quite differently. They work in a way that is really assertive and really flexible and really able to respond to need. So they will be going out and about to see people wherever that might be, and making sure that they're just in better place really to meet the needs of that community. It's the very nature of their work, and that's how in that respect. And what they also do is they work really closely with the other agencies, so they will link in really closely with services like the homeless mental health teams, street outreach teams, day centres, etc. So they're really able to provide that more effective support for people within the homeless community that might not ordinarily get access to that secondary care, which is brilliant. So I think that's it from me and my slide. Thank you.
So just to end the presentation, we've just put some useful links in the slides that people can access on various different things. In there as well is the information of how to contact the local mental health teams and our crisis teams as well that we have mentioned, and there is some other support kind of links in there as well about information as well.